what kind of made you start? It's almost always some type of anxiety relief that they're looking for. I hear that a lot. Many patients admit to me that, they've had anxiety and depression for some time, and this was a way to help them get, quote unquote, through the day.
Welcome to the Sober Spill podcast. I'm your host, Isabel. On this podcast, we have real conversations with people in recovery, their families, and organizations that pertain to this field. Today, I'm here with the host of the clinical side of our podcast, Jana.
Thank you, Isabel. My guests will discuss best clinical practices, new emerging trends in substance use and mental health disorders, and how we can best take care of ourselves and our loved ones in recovery.
See you every Thursday.
And come spill with us soon. Hello and welcome to the Sober Spill. Today I am so excited to be sitting with Dr. Hari-Kurapati. Dr. Hari-Kurapati is an internal medicine physician. She's also the assistant medical director here at Mountainside Treatment Center and our physician who is leading our outpatient withdrawal management, which we're going to talk all about today. But welcome so much, Dr. Ashwinii. We're so happy to have you here.
Thank you so much for having me. I'm so excited to be here.
Yeah, so why don't we start with just telling us a little bit about the kind of doctor and specialist you are and what makes your role very unique here.
Sure. So I am an internal medicine physician. I was trained in New York, and I was a hospitalist for well over 7 years. And I've also done outpatient clinical medicine. I first became Suboxone certified in 2014, which really brought me into the world of addiction medicine.
That was quite early, actually.
Yes.
That was really ahead of the curve. Wow.
Yes. At that time, there was already, I could see a clear need for a Suboxone, certification because we had so many patients even at that time in the hospitals who were on, or who had, unfortunately, different substance use disorders. So that was my first exposure to addiction medicine. And from there, I still did a little bit of, addiction medicine here and there. I worked for a wonderful company called Housing Works, where I was a medical director in New York City. And I kind of ran and assisted with their detox outpatient unit, also prescribing Suboxone and working with other wonderful providers who were getting patients off of very harmful substances. That center was excellent. We even had a clean needle exchange program upstairs from where I work. So I was really on the ground of, seeing a lot of addiction medicine patients. And fast forward a few years and my family and I moved to Connecticut and I started working for Mountainside last May. And I was hired actually to help with their outpatient withdrawal management or OWM program, which is basically a program that enables patients to get off of harmful substances, but in the comforts of their own home. And to have all the therapy, all the access to medications, access to a doctor like myself, and really, help them, meet them where they're at and get them the, services that they need to get off of something of the harmful or a substance use disorder that they really want treatment for, but they can't come into detox.
That's huge. I mean, we've always seen that. We've worked with many people, let's say like busy moms, they feel like they cannot leave their children, or people that have a profession that they feel like they cannot take FMLA, but they really do need that stopgap. They need a medical support to stop using to be able to live their lives. So, I mean, the big news, as we're airing this, as of today, in Connecticut, March 25th, Kratom is now illegal as of today. It has been scheduled as a Schedule I substance, which means it is illegal to purchase it, illegal to use it, and illegal to possess it in the state of Connecticut. So what are you seeing in our state of Connecticut?
Yeah, so, it's very interesting how packaging, really sells a product, right? Mm-hmm. And so with the legalization of cannabis, and cannabis being a gateway drug, we're seeing many, young patients, unfortunately, think that Kratom is just a herbal supplement to help them relax. It's being sold at gas stations, then vape shops, very accessible. And so what we were seeing is a lot of young patients taking Kratom, and, basically really not being able to get off of it. And, furthermore, going to even harder substances. We were seeing that clinically in certain patients. And we were even seeing patients who had successfully completed, like, let's say, an opioid detox program, were sober for years, off of, opioids, and then suddenly realized, oh, well, there's this, product called Kratom. It could help me. It went on Kratom, and then they relapsed completely back in spare opioid use disorder, which is, very disheartening, of course. And, and a lot of this is because of the way that it's being packaged and the lack of knowledge around what it really is.
Absolutely. I think that's one of the most positive things I think about the ban is that there is much broader community interest and much more education. I know we've been, a lot of people have been seeking us out, asking for education because other treatment centers often don't even realize what a problem this is. So I know you have treated several patients within our continuum. I mean, we've had over 100-fold, percent increase in our Kratom, our clients presenting with Kratom use in the past year. It doesn't have a formal diagnosis per se, right? I mean, we use the F1999, and can you explain that a little bit?
Yes. So here's what's interesting. When these new substances hit, unfortunately, the public, in medicine, we don't quite have the diagnosis because some of these substances are in more than one category. For example, Kratom has both opioid characteristics as well as sedating characteristics, right? Chemically in that drug. So we're right now kind of, using a general category of opioid use disorder or sedative use disorder. And I'm asking the patients, were you on Kratom or, and then they provide a little bit more information. There's another offshoot of Kratom, which is 708, which is even more potent than Kratom. And so we even have patients saying, I was on Kratom, but doc, now I'm on the 708.
And that, to the best of my knowledge from everyone that I worked with, is a much more, not much more, because I've worked with plenty of people actually that were so addicted to the powder and taking like 100 grams of it, plus, and then they switch over to either an extract or a shot of the 7-OH, the 7-hydroxymitragynine. And we know now too, there are several other alkaloids, besides 7-OH, because the DEA is trying to actually ban 7-OH federally with the FDA now. So my concern sometimes is that, like you said, we're sometimes, I don't know, you can correct me if I'm wrong, but like medicine is behind the market. Like the market is selling all different things we know with crypto and on the dark web that we don't even have classified yet.
Guilty as charged.
Oh, no.
No, I don't. I mean, listen, medicine is constantly evolving, right? Because we have so many different aspects of it. When we are, back in the day, for example, internal medicine, we would have a patient, and once they had blood pressure, we would, give them blood pressure medications. Well, now there's, this wonderful field, preventive medicine, which is fantastic. I had the privilege of learning preventive medicine. I worked in a clinic, and that analyzes a patient and says, okay, what are you at risk for developing? Let's give you everything you need to prevent you from becoming hypertensive. Let's give you everything you need on you with very, very good lifestyle choices so that you and your family do not develop type 2 diabetes, right? Which is very, prominent and genetic based, et cetera. So, in medicine, we are also evolving, and addiction medicine is a field that's also constantly evolving because, as you said, there are new substances. So, a lot of times my colleagues and I are informing each other.
Yes.
Based on what we see. Hey, this is out there. I had 2 patients on this. Watch out for this, So, you're right in the sense that, we didn't know how harmful Kratom was. And now, thank God, we have data. Right?
Yeah.
Because data is something that really enables us to make a point that, listen, this is a very harmful substances. It's getting into the hands of our, young college students. It's on campuses, and we need to make everyone aware of it. And yes, we need to treat and help patients detox, but let's also do the preventive medicine aspect of it, which is keep it out of people's hands to begin with. So yeah, I will absolutely agree with you that, in general, we are a little bit behind because we are becoming aware of how dangerous substances are once they enter, unfortunately, the public population, and we then collect the data and we realize, oh my goodness, this is a very harmful substance. And I here at Mountainside, we were very good about quickly identifying Kratom. We were one of the first centers to start a detox program for it, take patients in immediately who had the Kratom use disorder, and I consider ourselves to be at the forefront of this.
Absolutely. I know we've helped a lot of people. And I think I love what you just said, too, about education, preventative measures, and then putting in protections as preventative medicine. That's a really interesting way to formulate preventative measures. How do you do like an outpatient withdrawal management, which sometimes in the community they call an ambulatory detox or like an outpatient detox? How would you treat that with someone that is struggling with Kratom or 7-OH?
Okay, so that's a great question. So first part is the patient would have to reach out to us and explain kind of what they want. So let's just use let's say that there's a woman, her name is Ashley, okay, random name. And she's, 46 years old, very busy mother too. She works part-time from home. And she realizes that, she is very dependent on Kratom. It first started as a recreational use to help her with some anxiety and to help her with some, let's say, symptoms that she was feeling. And then she quickly realized that it escalated. And now when she doesn't get a dose, she sees that she's having severe symptoms of withdrawal. So she reaches out to Mountainside. We basically introduced her to our OWM department. They do what's called general assessment. And, we always offer all of our services according to what the patient wants. Now, Ashley, in this, particular instance, says, no, I can't come into detox. I'm a caretaker. My children depend on me. So then we say, okay, how about we do an outpatient withdrawal management? And what that entails is having a medical doctor like me meet her on televisits, see what's going on, what she needs, determine her use, get her prepared for how it's going to be when she stops Kratom. Now, if the use isn't very long, she may not need pharmacological assistance. Okay, so not every patient on Kratom necessarily needs to go on pharmacological assistance. So the use is, let's say in her case, this has just been going on for a month or two, and she's never used opioids before this. Then we would say, okay, let's, stop the drugs. Let's give you symptomatic management, right? Which we do very well. We can treat shakes, tremors, nausea, vomiting. We know that she's going to experience these things, just probably in the short term.
In the withdrawal, so the shakes, nausea, vomiting. I mean, one thing I've heard from people with Kratom withdrawal is like horrendous restless legs and profound anxiety. Yeah. So how would you treat those symptoms while someone's an outpatient?
Yeah, so great question. So it depends on their specific withdrawal. So first we have to so we would give them like general medications that they would have in their home. Nausea medications for, diarrhea. We would use medications that are, again, non-addictive, because what we don't want to do is give highly sedating medications to someone and then create a secondary use disorder. So, for example, we'll use hydroxyzine, which is an anxiolytic or an anti-anxiety medication in the short term. If the patient says, you know what, I feel anxious, but I've had this since I was a kid, where if I get up on stage, I get a little stage fright, then we could use something like propranolol, which is it's a kind of in the beta blocker family. It decreases blood pressure and, most importantly, heart rate. And again, this would be in the short term, because the withdrawal, depending on the usage, isn't necessarily very long. Now, conversely, if we had somebody who had been on, and we did have a patient like this, who had been on, a heroin and very, very strong opioids in their 20s and 30s, and then discovered Kratom, and then wanted to, she had children and she wanted to, be sober from everything. On her, in addition to the symptomatic management of nausea and vomiting and, treating those symptoms, we also offered Suboxone, which is used for Kratom withdrawal. And she wound up doing very well. And we were able to get her off of Kratom.
It's amazing. And I know a lot of people in the community that come to my support group, like nationwide. Many people are using Suboxone. Would that be considered, and they're getting it prescribed, they're not buying it off the street, they're working with a provider. Is that still considered technically off-label at this point?
You tell me, because in a couple of weeks, everything's going to change.
I think that is the best answer we can give right now. It is literally the ground shifting beneath us right exactly at this moment. We know it's helping people because I've directly asked Suboxone, Sublocade, and Withdrawal representatives about this, and they always tell me they can't actually provide anything concrete at this time, but they also say we know in the community that people are using this to stay off of Kratom and to get off of Kratom. And even last night in our support group, we were talking to many people that are on Suboxone and Sublocade that have used it shorter term in my experience, because I've worked with many people that struggle with opiates for many years, and I've seen them use, like Sublocade for maybe a few years and then titrate down. And what I love about Sublocade is there is, like an evidence-based, FDA-approved way to titrate down. Unlike with Kratom, when you try to get off of it, it's a lot of Reddit support. It's a lot of different titration schedules and people are helping each other out, which there's a beauty in that, but there's an irregularity, especially in that what, let's say I was using, what dose I'm using, what potency I'm using is likely very different than what you're using because of the mismarketing and the mislabeling on the packaging and on the actual product. So I find people really struggle when they're trying to mimic someone else's titrate schedule they found online versus getting off of, again, an approved medication that has like a quantifiable, process.
Sorry, you need me.
I know.
I would tell patients, please go about it with a licensed professional, because again, we know what we're doing, and anytime, let's say I prescribe Suboxone, it isn't necessarily a fixed dose for a fixed time. It's a let's see how it goes, right? Because in the initial period, I am going to have a higher dose, right? Because they're coming off of a substance that they had a very bad withdrawal, right? So, but that might not necessarily be the maintenance dose, right? The dose that they're going to use every day for a couple of months might be much lower. So these kinds of titrations, really, I would strongly advise a licensed medical professional. And it's not only MDs who are Suboxone certified. We have nurse practitioners who are Suboxone certified. We have physician assistants who are Suboxone certified, but just somebody who understands, how to titrate Suboxone, and how to titrate these, medications, and also really cater the plan to that patient. It's not a one size fits all. Right?
No, it's not. And especially with different bodies, women's bodies, men's bodies. I'm so appreciative of the two examples you gave, or just, hypotheticals of women, because when I went to the 5th annual Kratom Symposium, Nora Volkoff from NIDA, who's been the director of NIDA for like 23 years. So Dr. Nora Volkoff presents a slide from Johns Hopkins University that says 61% of Kratom users that report using, frequently throughout the week are women. And I was like, that's not true. And then I really started to look at it, and in informal research, because that was more hard research. Then when I went out to vape shops and asked a lot of the people that were selling it, who's coming in, and I happened to do this in Fairfield County, Connecticut. And the response I most often got was women like you, and I'm a 48-year-old mother. So, it just was interesting to me. And since, doing a lot more talking about Kratom publicly, I've had many of my peers in my community come to me and acknowledge they've been struggling, that they started on this for often pain relief and energy, like that combination of being a full-time working mom and needing something maybe to relieve some chronic pain, some of the perimenopausal, frozen shoulder, whatever it is, but then being able to be fully engaged and alert, because Kratom in lower doses has that stimulating effect.
Right.
But then there comes a point, and especially now for moms in Connecticut, I think it's quite scary. A lot of people I've talked to are like, I don't want to do an illicit substance.
Right. So, and that's where we really need to embrace the patient and make them feel very, comfortable and safe, and understand that, we want to help. And we really need to remove the stigma and make it a safe space for all patients, including working women, including moms. And we need to kind of approach this in a way that, let's help you live your best, likes, both with mental health and physical health. And you're absolutely right. When I talk to patients on Kratom and I ask them, what kind of made you start? It's almost always some type of anxiety relief that they're looking for. I hear that a lot. Many patients admit to me that, they've had anxiety and depression for some time. And this was a way to help them get, quote unquote, through the day.
Yep.
We are seeing, very, very high rates of, anxiety and depression in general in our, population. So speaking about this openly and saying, let's make part of your treatment plan also addressing the anxiety and depression, right? Like, let's give you the healthy habits that you can then rely on once Kratom is out of your life.
Hi, I'm Ricky, recovery support clinician here at Mountainside. For veterans and military families facing addiction or mental health concern, Mountainside is here. We accept Humana TRICARE and are a proud member of VACCN, ensuring accessible, high-quality care. Our specialized programs and staff with military experience understand your journey, providing the targeted support for healing and recovery. If you or a loved one needs help, please call 860-824-1397.
I think that's so important. And I think we know that well at Mountainside, but I feel like that's one of the important key points of education, that it is marketed so much for pain relief, but most people I've worked with do, as you just said, struggle actually with pretty profound anxiety, and they find it works until it doesn't. And then it creates more anxiety. And the withdrawal can be pretty horrific of getting off of it and feeling so anxious. They can't leave their couch. They can't go to work. They can't show up for their kids when they're trying to abstain.
Exactly. And I will say that clinically, I have a lot of compassion for patients who have anxiety. Anxiety I've seen in the clinic setting. I have seen panic attacks in the hospital. And it's, I compare it to a person running on a treadmill and they catch their breath and they can't get off the treadmill. Physically, it's a very, very tough state to be in, physically and mentally. And so, I always tell my patients, we have ways of, addressing this, and long-term management of anxiety, right? Whether it's with pharmacological help or non-pharmacological, which involves things like meditation, deep breathing exercises, right? 4 in, 4 out, right? Like these types of, exercises that we have and that we encourage. Cardio exercise every day, which is a great way to start the day, burn off a little bit of, nervousness. And a lot of patients really report some relief after, really setting up a good cardio routine. So long-term management of anxiety and encouraging, non-pharmacological, and if anxiety is severe, then yes, pharmacological help as well, but under the care of a licensed professional, right? Because self-medicating is very dangerous. And many times, a lot of different substance use disorders that we're seeing are patients self-medicate. I feel horrible. I'm going to reach for a drink, right? And it's almost like they're doing what they need to get through the day. And then quickly they realize, oh my goodness, I cannot get through the day unless I do this, right? And then that's where the addiction starts. It's a fine line between, intermittent occasional use and addiction, right? So that's what we see clinically, Jana.
Wow. Yeah, I appreciate so much your perspective and knowing, like, again, that you've been working with Suboxone now for over 12 years. You've really seen the shifts. And that's an interesting time too. When I look back, both of us have worked, in addiction treatment, through the height of the opioid crisis. And I think that somehow relates to this whole conversation we have. We know many people, like you mentioned, there are a lot of people that started Kratom that have a history of opiate use, maybe 10 years ago. I mean, that's where a lot of people I talked to too. And they got off of it and they felt so much relief and they are proud to have lived through this and made it through. And then to get stuck again with Kratom. And it's a different host of, I think, fear, because, and I often hear, and I feel like, I don't want to say it's a low bar, but people say, well, it's better than fentanyl.
Right. So we hear this a lot, right?
Yeah.
So I even hear this about cannabis.
Okay, tell me more.
Yeah. So I heard this was first said to me by a young man in New York City, and just saying, come on, doc, like, cannabis is okay, right? It's not that bad, right? I get this a lot. So I say, okay, give me the situation, right? Give me the clinical situation, right? If I have, and I have had these patients, I have a 62-year-old, woman who has advanced metastatic breast cancer. We're talking about breast cancer where that spread everywhere in her body, including her bones, extremely painful. Her body's been, through a lot of chemo, and she's had tremendous weight loss. And I'm sending her home on hospice to enjoy it last summer with her family. Cannabis may help her because it's an appetite stimulant. It helps with anxiety relief. It even helps with pain control in that stage. So in that clinical scenario, is cannabis appropriate? And I would say 100% yes. And most oncologists would prescribe it themselves, If I'm talking to a 19-year-old, young woman who's trying to find her way, and she's in a university and she's trying to absorb, course loads that are challenging and are meant to be challenging, is cannabis, which is a central nervous system depressant, ideal? I would say 100% no, right? And I had this clinical scenario. I had a young single mom who was trying to better her life, and she was going to law school at night. And she was getting stressed out about taking the bar, which is understandable. It's a very difficult exam. And she came to me and she was like, I was thinking, I'm a little cannabis. And I told her, listen, you want your brain to be razor sharp. Your entire study these last 3 years relies on you passing this exam. And I see that you're, struggling to, better your life. So I'm not going to recommend cannabis because it's going to depress your brain function when you want it to be razor sharp for this exam. We can, however, do other things to help with this anxiety. So a good doctor isn't going to say this substance is horrible. This substance is, fantastic. Give me the clinical situation. These substances that we're flooding the market with, that are making their way into the hands of our young 20-year-olds, 19-year-olds who are at universities, colleges, trying to create the foundation that's going to build their life, right? That's what you do in your 20s. Mostly, are these substances, good? I would say 100% no.
Yeah. And I love what you just said about there is some nuance to this. Give me the clinical presentation. I feel like right now in 2026, we're living in a very binary world context, politically right or wrong, black or white. And you're absolutely right. There's a lot of nuance in these conversations and a lot of individuality and really listening to someone. And I love
Exactly. And that's why I encourage everyone, go to a licensed professional. So I always say, give me the clinical situation. But Kratom and these substances that have no FDA regulation, that we are seeing harming lots of people, that are making their way, even if you think about the purchase, these substances being in a gas station. Yeah. Do we want this in the hands of young drivers or older drivers or any driver for that matter? When I found out that this is being sold in a gas station, my first thought was, why do you need this on the road?
That is a very articulate, astute point. Why do we need this on the road right before you check out, right on the left, right on the right, not even behind the counter? I mean, that's what gets me. It's like we keep the cigarettes behind the counter, but we keep a psychoactive drug in arm's reach. I mean, it is quite strange. And it shows you too, again, the market. It's a multi-billion-dollar industry. It was marketed very well as a cure-all, marketed very well, as an Asian botanical. I'm curious if we can go back to cannabis for a moment too, and just talk about sort of the destigmatization of cannabis. Because again, you've come up in your career in a time where when we both were started practicing, it was illegal. I mean, it's still federally scheduled, but that might be shifting, and now it's legal. How have you seen the way that we view cannabis change over the past decade plus?
I mean, I see a lot of patients, young patients in detox who start much earlier now, like 13, and they're using it every day. Now, keep in mind that, all these things we're doing with the laws, our human brain does not change. And, during development, like you are still a child at 13, your brain is still developing, right? And in the same way that, pregnant moms are very careful when they're pregnant, right? Like when I was pregnant, I didn't look at alcohol. I didn't touch alcohol. I had one cup of coffee. That was it, right? Because I knew my baby was developing, right? And any harmful substance I ingest goes to them. Now, in that same way, when a child is 13 and they are taking in these strong central nervous system depressants, which is what cannabis is, it's a depressant.
A strong central nervous system depressant.
Cannabis. And they are in that period where their brain is developing and they're also learning, right? They're in school. And so now when I'm talking to my patients in detox and they're giving me their history and they're telling me, oh, I was on it every day by the time I was 14, I know that we're going to have our work cut out for us here at Mountainside to really help these patients detox and stay off of, cannabis because they're used to it, every day, right? And that's a 6-7 year use period. So now we're seeing withdrawal. The cannabis itself it does not have like a very severe physical withdrawal. Okay, it's not really supposed to. We see things like irritability.
Yes.
And you see a very
massive irritability. I would clarify, like, some of the most irritable people I've seen are coming off of daily use of cannabis.
Yes, exactly. And you see like also these patients have a very, very high amount of anxiety.
Yeah.
Because you're on something that's sedating you every day.
Yeah, it's very interesting what we're seeing with cannabis now. It's almost been so destigmatized now with the movement towards medical and recreational cannabis over the last 14 years in this country. So it's interesting to see that shift. And now we know again it might be reclassified and scheduled differently.
Right. So, what I tell my patients is not everything that's legal is good for us, right? Alcohol, for example, right? We have, very, very high rates of alcoholism as well. So, it is a legal substance. It's everywhere, right? And yet, we have, many patients who have alcoholism. So in that same way, I represent, cannabis use as, listen, yes, it's legal and it's available. But do we want this in the brains and bodies of our young developing teens who have so much to go through? Their childhood is already so different from ours.
Absolutely.
Right? And in the same way that, you think about, like, I know so many moms who are like, no sodas, right? Like not even a drop. I fit in that category as a mom myself. I have 3 children. I think about all the time what's, what kind of nutrition, what kind of food they're eating. We don't have sodas. We don't have much candy in our home. And all of those are very positive changes, I would say, because, moms recognize that we have a very high degree of obesity and childhood obesity in our country, right? So in that same way, I would ask young moms or any moms, or anyone to think about in that way of what you're putting in your body between 13 and even 25, or you're really developing and your brain is absorbing so much information. Do you want something sedating that process? Do you want something, decreasing that ability that your child is still developing? I've had young college students come to me and say, oh, doc, I didn't do good in college. I dropped out. And I say to them, I said, listen, your prefrontal cortex, which is, the area of your brain that makes decisions, that plans, that, does the executive functioning. I remember a neuroscientist professor telling me once at UCLA, you are your prefrontal cortex. That is fully developed at age 25. So, we know that. We have that science. So, but I would say to them, arm yourself with this knowledge of what you're putting in your body. It is not going to help you ace that science class. It's not going to help, with any real thing. It's not going to help you live your best mental and, physical health-based life, right? And really think about that, because there are substances that are legalized, and different countries as well legalize, different drugs. But is it something that's healthy for you? That doesn't change. Alcohol is not healthy for you. Doesn't matter if it's legalized. I had a middle-aged man recently who developed a really bad blood pressure issue, but he was drinking lots of alcohol. And I told him, listen, your hypertension, I can link to this. This is something that's known in the literature. Now, what you do with this knowledge is up to you. We can give you more and more blood pressure medications, or you can really cut down on your alcohol and you'll see your blood pressures behave. Now, luckily, this was a gentleman I had a very good rapport with. So he actually cut down his alcohol intake tremendously, and his blood pressure came down tremendously. So, these kinds of substances, no matter what we as a society decide about them, legal or illegal, their chemical nature does not change. Their effect on the brains does not change. So I would say to moms, we don't let our kids drink soda so much anymore. We really should warn them from the get-go about marijuana, about cannabis, about drugs that are legalized, because they are not good for the brain.
Absolutely. There is so much here, Dr. Ashwinii. I am curious, can you do an outpatient withdrawal management for alcohol or cannabis?
So that's a great question. It depends again on the patient, right? So if I have a patient, what we worry about with alcohol withdrawal is that the withdrawal is severe. And in many patients, if they're not appropriately medicated, we can have very drastic consequences like seizures. So if a patient has been, on alcohol, for a long time, and they've had multiple withdrawals and they've had a history of seizures, they really should be in a proper detox with us. I feel very good about having my patients here at Mountainside Detox. We have 24/7 nursing. I can see their medications. We have a doctor looking in on their whole, care plan. We take excellent care of them. And even here, if the withdrawal comes too severe, we send them to the hospital because that's where they belong. But if it's a patient who's, let's say, had no history of seizures, their alcohol usage is, pretty light to moderate, we could do what's called a very, closely observed withdrawal, where we get the medications, we get them off of alcohol. We're doing assessments every, 4 to 6 hours. And those assessments help us determine, can they stay at home? And we do what's called CWA measuring, which is basically a score that enables us to see how bad the alcohol withdrawal is. And in many of these patients that we are detoxing at home safely, their CWA scores are going down every day. So we know, okay, that's a safe withdrawal. If at any time it starts to go up, we say you have to come in, or your choice is the hospital. So I feel very good that Mountainside is very careful about, detoxing our patients. But yes, certain types of alcohol withdrawal and cannabis use disorder and Kratom use disorder can be managed at home in our outpatient withdrawal management.
Wow. Thank you so much, Dr. Ashwinii Hari-Kurapati. Thank you for the work you've done. You have been on the front lines for a long time, and I'm really grateful that you're here with us. And thank you again for meeting people where they're at.
It was my pleasure. Thank you, everyone, for having me. It's a real honor to be here.
If you or a loved one is struggling with addiction, Mountainside can help. Call 860-365-6764 to speak with our caring treatment team.